President IAX, Dr. Zilla Singh Meherwal, Secretary IAX, Dr. C.S. Hiremat, and Senior Vice President, Dr. Lokeshwar Rao Sajja, on stage to chair the C.S. Sadasivan Memorial Oration, which will be delivered by Dr. Prassana Simha Mohan Rao. Dr. Prassana Simha is the Professor of Cardiothoracic Vascular Surgery at the Sri Jayadeva Institute of Cardiovascular Sciences and Research in Bangalore. He is actively involved in teaching and student education. He was the scientific chairman for IAXCon Bangalore in 2017 and 2021. He is the co-chair of the IAX SCORE program held at Bangalore every year in March. He is actively involved in the IAX database and is a committee member of that program. Dr. Prassana Simha has over 35 papers in peer-reviewed journals. He is a regular faculty speaker in IAX conferences and the SCORE program. He has conducted multiple workshops on mitral valve repairs, accidents during cardiopulmonary bypass, and training wet labs for students and juniors and mid-level consultants. He is involved in translational research with various institutions. His endeavor is to improve recruitment of students to cardiac surgery via IAX. He is passionate about improving the visibility and profile of cardiac surgery. He has interfaced with authorities for better remuneration through various schemes. He has advised various entrepreneurs trying to develop products and working in conjunction with BES Lab, Cell Biology Department, ISC, GE Healthcare. He's been involved in multiple center trials as a principal investigator. Dr. Prassana Simha is the past Reeve Betts Fellow and KN Dastur Orator for the ISCTS.
I welcome Dr. Prassana Simha Mohan Rao to deliver the prestigious C.S. Sadasivan Oration. Request all members to be seated and close the doors, please.
Good morning, ladies and gentlemen. It gives me a great pleasure to give the Sadasivan Oration today. Can you please give the sound, please? Audio?
Medical College. Trained in Karolinski, Stockholm, and with Dodd Brock in London, he showed special expertise in lung and closed heart surgery. He was known for his humility and compassion towards patients. He died at the early age of 53 in 1970.
We salute him, and this oration is in his honor. I would not be what I am if not for my parents. Late Professor Mohan Rao was one of the pioneering vascular surgeons in India. And my mother, Mrs. Shada M. Rao, and my family. A teacher sees through the eyes of his students, and I'm grateful for Professor A.G. Tendulkar, who gave me that sight to be able to be what I am today, and my senior colleagues whom I worked with through my journey from being a junior cardiac surgeon to what I am today. And I'm always grateful to my institute, which helped me, Jayadeva, which helped me blossom. The Red Queen said in Alice, it takes all the running you can do to keep in the same place. If you want to get somewhere else, you must run doubly fast. And this is something which we have to do. We have to keep running. Because with new percutaneous techniques developing, surgeons have to meet this challenge and innovate and provide multiple solutions. So this is my attempt at telling my story of how I tried to keep running. The problem when I started mitral valve repairs was rings were costly. This open heart surgery was costing 20,000 rupees and rings were costing 20,000 rupees. Gore-Tex sutures were costly. Failure was a disastrous event financially, and solution was this. And the solution was to indigenize. We always had a sword on our head when we were operating and trying to start the repair program. So I started using various indigenous rings, and the first one was using the Panath-Burr annuloplasty ring, which was there. Then I started using a pacemaker wire, and some of my colleagues have seen me doing this. And this was a very durable thing, surprisingly. It was truly flexible. It allowed good mitral annular motion. And this is an example of a patient done at that time, where you can see the pacemaker wire ring annuloplasty. And Here you can see the old recording where you can see the superposition in systole and diastole, where you can see excellent mobility of the valve, and you can see the aortomitral continuity being static, whereas the rest of the valve is moving. But it had issues. It could not remodel. So then I started trying to make it with pericardium, with Gore-Tex, and various other things. But all of these issues, because we deal with rheumatics, it could not do one thing. It could not truly remodel. And then I was a newly married man, and I saw my wife's thali, and at that time there is that gold wire, and I thought, oh, gold is biocompatible. And I thought, why not use a gold wire? But then I would be behind bars if I had asked my patients to get gold wire. So then I was walking around and then realized that the surgical stainless steel that we have is biocompatible. And then I tried to make my own rings. I had not seen, to be honest, I had not seen a commercial ring. The only ring I had seen was a pure Masana Shaili ring in a box with KEM, and I had not seen any commercial ring beyond that. And then I tried to get people to cut and make it, but the moment I said it is for medical use, no acrylic cutter was ready to do. So I bought a hacksaw blade and I made my rings initially. These rings worked very well, and even out to 20 years they have worked well. But then the problem was that it was a little cumbersome to suture, so I started covering it with Gore-Tex and other things. But then later on, I started making it with another biocompatible setting. That was a CVP line. I started putting the wire through one of the holes in the CVP line, and I fashioned that ring. I've used that for decades. And and it was a very good thing. And you can see even 10 years later when I opened for something else, you can see the ring working excellently. And I made my mitral and aortic sizes, and to be honest, I use these in the pediatric sizes. We don't have smaller ring sizes for kids, and I still use them. You can, and many of the ladies can think that thing holding is actually the knitting needle loop holder. And I started using it. Because the handles used to break, I started putting an artery forceps. Then same thing I did for aortic valve repair, and I even use these aortic valve repair sizes even till today. They were all made with acrylic. Now as far as, I started repairing, and then we were trying to find out what works and what not works. Because the common question that is asked is, what happens to these patients? Rheumatic repairs don't last and everything. And actually this work was done by Dr. Dattatreya, a cardiologist who religiously followed up my first 107 patients. He is no more. He died suddenly in a stroke at a very young age, unfortunately just before we could publish this. And we described the infra-PML triangle, which is the area subtended between the posterior leaflet, posterior LV wall, and the posterior leaflet. And then this is an example of a patient with an unfavorable triangle. And then when we followed these 107 patients to 10 years, what we found was that those who had an area of more than 1.5, 98% of them had been repaired at the time. Then if the area was less than this thing, it was 60% and somewhere between 85 and 90. And this is the criterion which we use today. We were actually having the follow-up work when my cardiology colleague, the young budding cardiologist, died, and we were not able to complete the follow-up of this. But we know that this was the rate at which we could repair. And this is something that we found very easy to use. We also use Dr. Sampath Kumar's AML height of 26 millimeter. We have reduced it to 24 because 24 rings are available now. Now, the common teaching is that when you have a bad PML, and I've been talking about it repeatedly, that posterior basal caudal release is something which we were doing. We were also augmenting, and here you can see the pacemaker, the wire, the steel wire and the neckline ring, which is been implanted in this case. But then we found that some of the patients, especially in young kids and teenagers, where we could have a ragged edge, come what may, we would have a lot of leaks, and it was a big problem. And these are the patients whom, if you implant a mechanical valve, you know they're not going to reach adulthood. So we described the veil technique, which we use selectively, and surprisingly this has done well, where we have actually replaced, we have overlaid like a veil, over the PML we have put a pericardium and sutured it to the ring and down to the papillary muscles. Surprisingly, none of these patients have come back, probably because it's impossible to have raised stenosis because there is this side pericardium. Probably in future this will and shall calcify, and then we will have to redo these cases, but This is something which we found does work, and we do use it selectively. And another thing that we found, and it was very important, this thing is, we were using it, and then we later saw that Kalangos actually published it. One of the problems is we don't publish, and we have got to do this, is that we use the contralateral tethering stitch, and this has helped make repair fairly easy compared to many complicated techniques for spot leaks. You end up, you do a repair and you get spot leaks, and then you find it very difficult to, and you would not like to close with that spot leak. And this helps manage spot leaks very well. And this is a transferable thing. My junior colleagues are able to do this very effectively. Then Gore-Tex cordae were very costly. And then there was this loop over loop technique by Tyrone David. Nice to describe, but difficult to do. You'll suddenly find one thing becoming tight. Good in Tyrone David's hands, not transferable that easy. So we were thinking what to do, because as a teacher, it should go down to the next level. So we decided to use what was called as combined chordoplasty, where with two cordae we can stabilize the entire AML. And what we essentially did is we did a chordal shortening, but rather than, it was a trenchless chordal shortening, because we knew that Carpentier had published that putting a trench can cause abrasion and cause late rupture. But with this method, we actually used the same Gore-Tex cordae to go back to the leaflet, and this was acting like a shock absorber and reducing the strain on the rest of the cordae. And we've been using this for approaching nearly 3 decades, and we have not had any structural failure related to this. And then another thing that we did was, when we had endocarditis, was that we found that we have to excise what is infected and then use. Then I saw Carpentier actually putting glutaraldehyde to the commissures. Then I said, why not make it a little easier by putting immediately around the area, because essentially the endocarditis, the leaflet is normal and gossamer thin. Taking sutures, even though you've debrided the infected tissue, the area around was very difficult to suture. So then I started tanning the immediate area around it, and you can see you could actually excise and you could suture these. So we were able to do it in a large volume of patients like this with extensive endocarditis. The other thing that we started doing is that in very small kids where there was no option with extensive destruction, like in this case, we started excising the posterior septal commissure of the tricuspid valve and auto-transplanting it to the mitral valve, and you can see cases like this. And I have had the pleasure of actually following up this patient 15 years later, and he is doing very well with moderate TR, but mitral valve is excellent, and it has actually grown with him. So this is an option which we use selectively in cases where replacement is just not an option. And of course, this was something which my teacher had taught me, Dr. Tendulkar, and iatrogenic, we get a lot of balloon mitral valve vertebral tears, and we are able to salvage a huge number of these. Now, we started getting confident. I don't know whether it was overconfidence, but over a period of time, the mix craze started coming up, and we had to do something. So we wanted to do, and there's a whole lot of ways, and what to do, we had to do something which was possible in my institute, which caters for the poor and this thing. So we decided that everything should be done, whatever we were routinely using a lower hemisternotomy by that time. So we said that we should do something totally endoscopic, but there should be no change in the preoperative plan. What we are going to do, we should not compromise on that. And we started the totally endoscopic program, and we quickly learned that we should not use a double lumen tube, because we started getting fulminant unilateral pulmonary edema, so we said that we are not going to use the double lumen tube. We started using echocardiography to this thing, and we started mapping. We found that all over the world, when it started, people were injuring the liver, other things, venous wires, everything were perforating and all those things. So we were using echocardiographically both transthoracic and transdising, and we were mapping all our plans. Today, these things look obvious, but then at that time, people were not doing it, and so we started doing that. And then I had the paucity of so many instruments. I had only some laparoscopic instruments which I bought. I had the scope which was there in the hospital. So I started using urological instruments. For example, to do fast catheter exchange through the ports, I started using the suprapubic cystostomy trocar, the metal trocar which you use. So we were able to introduce lines in and out very rapidly with this. And then cardioplegia site to put in the thing, that's a little messy if you want to pass it through the breast tissue. And also I started using a PCNL dilator, dilating the tract with the PCNL dilator, and then pass the thing using a Vaidya needle over which, and to prevent fat intercepting through it, we used to put, you can see the inner stillet of a arterial catheter. So we would retrogradely place this. Then we didn't have actually a good retractor. So then I was wondering what to do. Then I had laparoscopic training in my MBB through Dr. Tehampton Hudwadi when I was a student. We did the first lap chole when I was there. He did the first lap chole. So there was a thing called as a puppet string technique for cholecystectomy. So I said, why not adapt it? And we published this, where we started using we put a sling of the pacemaker wire, and then we started putting these sutures. And just like how you can manipulate the puppet, we were manipulating the RA and the LA, and we could get excellent exposure. And many of the pictures that you see are actually there. Similarly, we started using an IVC Foley. We were giving antegrade cardioplegia, retrograde cardioplegia. We could insufflate with carbon dioxide. And you can see the excellent view and the surgery that we could do. For example, is a rheumatic repair where peeling was done, commissurotomy, subvalvular release, everything was done. We were able to do LA plication, maze, and all of these were done through a periareolar incision. And this was cosmetically very excellent. You can see such cases which were done. And in the first 6 months, we analyzed our data, and we did 39 cases in the first 6 months. I mean, we were gingerly proceeding with this. And we were able to repair these cases, and you can see the excellent cause. In fact, if you see, we realized that if you take sutures, the scar of the ports in the tubes looked worse than the thing. So then we started gluing the skin to give a better cosmetic result. But then life is not a bed of roses. We had arteries, we had perforations of the SVC cannula, we had wire perforations, we had bleeding from port sites, we had RPA tears, and so we did a lot of work through this, and then the pandemic came in, and then we were not allowed to do thoracoscopic work. We are coming back slowly with this. So between 1997 and 2022, most of our cases were rheumatic, and happily the number of rheumatic cases are coming down now, and the myxomatous cases are coming up. In 2001 and 2004, this is very biased because patients may have gone to Saint elsewhere for their redos, but we had 34 redo replacements, 5 redo, all are rheumatic. We had 5 redo replacements for late endocarditis. And then we've had, for non-rheumatics, 3 redo repairs. And then we have had 3 redo repairs for myxomatous valves. And this was 1, and 2 of them actually were because we had done a P2 prolapse repair and used Prolene at that time. And the sharp edge of the Prolene unfortunately perforated the opposite side. We stopped using Prolene and we switched over to Ethibond when we are doing the repairs. And the other was from AMML prolapse. So why repair? People keep asking me, why should you repair? Why should you repair? And I had to sit and fight with people over the years. For example, this boy was a child, and he came with his wife, and he's happily married and this thing, and this makes it worth it. He came last year with his wife, married, and this is why we should do it. Now, we do not follow up our patients very well. Let's be honest, most of us are not. So we started trying to do, can we do something about this? So we took, by this time, my students and junior consultants were doing P2 prolapses regularly. So this is the work which was done of the cases which they had operated between 2014 and 2021. And one of my students phoned up, tried to follow up, and this is it. And those who had died, we had the last recorded echo retrieved from relatives or from our record. And we had 69 patients done, and we had 1 death post-op because of unrecognized innominate artery stenosis, and he didn't wake up. He was having good repair, but he didn't get up. But after that, when we followed, we found that they were very stable in their results. And as expected, we used the Megoon imbrication technique, which is, many people talk of resection, but as a teacher, I should be able to dismantle the repair if something is done wrong by them. If it is resected, it's not easy to get back and repair. And we found, and then when we got some sobering results. What we found is that despite not having MR, in the last recorded disease, we had 7 people who died on the way, and somewhere between 3 and 5 years after surgery, and all of them were sudden cardiac deaths or strokes. So this behooves us to be able to see, we talk that our patients are doing well, but when we actually follow up, we find it. And now we know that MVP is a risk factor for sudden cardiac death. So now we have instituted a policy of having a Holter monitor and all of our myxomatous valve repairs at the end of 3 months to identify that substrate of patients who probably require ablations or whatever. We have to formulate our policy. This is what I'm trying to highlight, that we were not following up our patients. We thought we were doing very well, but then we identified a totally new different problem that we have to be able to this thing. So we need to follow up our patients. We claim we do, but we have to do. So that's the importance of systematically following up our patients. We have done re-repairs both for rheumatic, less for rheumatics and for those with endocarditis, and these are selective. It can't be done for all patients, but yes, we have done them. And then we thought there's a large subset of patients whom we cannot repair calcified valves and this thing. And between 2007 and 8, we did a series of mitral and tricuspid DIAC procedures, which is an autopericardial dressing which looks like the frustum of cone. Radu DIAC is a Romanian surgeon, and he had described it. And we did those surgeries at that time. And then we were doing it up and on less often. It was a little cumbersome method. But then 10 years later, I thought, okay, let's follow up them. We found not a single structural degeneration in any of those patients who had been operated, which was stunning. I mean, even I couldn't believe, but when we systematically called them, so then I thought, okay, this is something good. But then we had issues with that, and so because it's not a very easily transferable operation, because even a minor torsion can cause it to not fit very well. So we thought, let's devise something, because we now knew that this autopericardial valve works. So we described and we did our pilot study, and this is a work in progress where we started manufacturing on table an autopericardial valve, which is based on the dimensions of a predicted normal valve, and it's mounted on, and you get what we can technically call as a completely flail valve, which we repair, and you can see it looks like a normal valve, very gratifying valve. So that's a work in progress. We have actually registered in CTRI, and we are recording this thing. At that time, the pandemic occurred, things went a little haywire after that, but now we hope to do it. So as far as the tricuspid valve is concerned, we were initially, all of us were D Vegas, then we came to know that D Vegas is not so good. Then we started using things like Gore-Tex, felt, pericardial strips, everything to avoid this. Then we started using selectively K-stitch for this thing, because we found D Vegas this thing. And then we started using Gore-Tex ring, pericardial strip. And this is an example when then we started using the indigenous ring which we made with, we found excellent results with it. And just because it's a complete ring, I mean, because we were closing VSDs, we knew how to deal with the area of the, in the region of the conduction system. So I used to just take it on the septal leaflet, and you can see the excellent results that come. And they have worked very well in our design. The issue was that many of us, we implant the ring, but we find that there is tethering because of dilated RVs. And then when we were dealing with these patients, things look good, but when you do the saline test, you get the terrible result, leaking in the center. And many people would just accept that. I wasn't ready to do that. So then we started treating it, we said that this is a ventricular mechanism, so we started elevating the papillary muscle like how Irwin Cron had described, but here we elevated the papillary muscle and put it to the ring near the septal leaflet, and we put a contralateral tethering stitch, and you can see the same valve where the water is not holding and this thing. And we've been using it for patients with extremely dilated tricuspid annuli of 45, 50, and which many people have said are technically not repairable, and we've been able to show that. We have actually presented this data in this conference. Then another thing that we did, which helped us in tricuspid valve surgery, was, I think all of us have had cases where we've done a good job, we've taken the patients, but progressively there's a rise in LFTs, and then the patient goes into warm shock and requires various inotropes, and then by 7th or 8th day they die of progressive liver failure. We had deaths like that, and I incidentally had a patient who had an IABP on, And I was seeing why this patient dissing, and I was doing the ultrasound abdomen, and then I noticed that the hepatic artery was in spasm. I could not get the hepatic Doppler signal. So I gave sorbitrate under the tongue, didn't work. I gave sorbitrate, IV didn't work. And I had that IB pain, so I just gave nitroglycerin to it, and lo and behold, the hepatic artery started pulsating. So then I said, I realized that you have to have it intra-arterially and not intravenously. It is just like how, and I got this idea because for mesenteric ischemia, we have in our general surgery books hooking up and putting it, but hooking and putting it is not so easy practically for us. So we did a study where we started putting it in suprahepatically intra-aortic perfusion with nitroglycerin preemptively in patients with significant hepatic dysfunction. We noted hepatic arterial vasospasm on a Doppler up to 72 hours. So essentially you are having a patient who is dependent on the, patient with hepatic congestion has got a greater perfusion of the liver from the hepatic arterial circulation other than the portal circulation, and this can cause a sudden vasospasm can set in ischemic process. And we realized, and we actually showed that this vasospasm stops and then comes back. If you stop the nitroglycerin, the artery goes into constriction. You restart, it goes back. So we used to do that daily, and we saw this spasm going up to 72 hours in some patients. And we have been doing it. We have been able to take patients with the childs A and B and do surgery successfully in them. We don't obviously do in child C because they should be getting a heart and liver transplant. So then we didn't have ventricular assist devices and things like that to do. And then what happened is, it should be 2007. So we wanted to see how low can we go with and do successfully. We started taking most of these patients who we could not have operated with this intra-arterial NTG and all that. Suddenly we were able to do. So we became exuberant. But then you have patients whom you don't come off bypass. And so we started seeing that. So we started looking into our data. And we took patients and we tried to see which is between 2009 and 2013, we reviewed our data, 456 patients. We started taking them, recording their data and seeing what happens to them. And we divided them amongst them. And so we had 456 patients, and we divided them into 4 groups: those who had a high PA pressure, those who had a low PA pressure, those who had a TAPC more than 10 and less than 10. And you can see here that all those who died, there was 100% mortality in those who had a low PA pressure and a low TAPC below 10. 100% of them died, not a single survivor. That was what we said we have to stop. We can't offer conventional surgery for those. And with that, we then stopped having these issues. Once in a while you run into problems, but we realized that low PA pressure and low RV function means that the ventricle is so gone. You can have a TAPC even 6, 5, but with a high PA pressure, that ventricle can kick, but this can't. So that helped us a lot. And so now in addition, we are adding MRI to detect scarring. We've also been doing, in conjunction with Indian Institute of Science, various studies to determine and elucidate the mechanism of surgery of this inotropic resistance in these patients. And another thing that we learned is don't do small operations. People, see, when I was a student, we used to want to quickly get in and quickly get out in the sickest of patients. I progressively learned that's the wrong thing. You have a giant RA, this thing, go plicate the ventricle, do a maze, do the complete operation, and be perfect in your myocardial preservation. We were using voodoo cardioplegia, my senior alumni and I were preparing voodoo cardioplegia somewhere in the middle of the night. But today we have very standard cardioplegia and we can have good myocardial protection, and that's very important. Similarly, I still continue to do the tricuspid DIAC procedure because it somehow seems to work well in the tricuspid position. It's far easier to do than in the mitral position. So you can see here we have done kids and patients with extensive tricuspid endocarditis, or this is another third slide, shows a patient who's literally his tricuspid valve is non-existent when he came for surgery. And when we try to excise all the infected material, you end up with a big hole. Now the issue is getting bioprosthesis is also an expensive proposition in many of the teaching institutes. So I started using the tricuspid valve this thing, and I'm happy to say that this is a very stable operation. I was surprised, and even now that just recently I showed one of the early ones to one of our cardiologists, and he was also very surprised to see that compared to we've had bioprosthetic degenerations much faster than these. And you can see this is how it is done, and you can see an excellent thing, and it looks like a normal tricuspid valve. We combine it with mace, geese, everything, whatever. It's a very nice operation, can be done on a beating heart, and it gives you excellent result. And as I said, from 2007, we've had no replacement, but we do expect replacement in children as they outgrow. But then we tend to try to put the biggest thing, because we are not, they'll be having a dilated annulus, we try to put the biggest thing in possible, and I expect that we shall have those. As far as the aortic valve is concerned, we were always trying to repair. We have done repairs for simple repairs like central plication. We were originally suspending it using trusslers, but later we learned that it's more important to not have a saggy bottom. And if you have a saggy bottom of the cusp, it leads to failure. And so then we started using more and more complex thing. When we started with the initial VSD ARs with mild, moderate AR, then we progressed to severe AR, then we started regularly doing bicuspid aortic valves, we started extending it to David's, and you can see this thing, then we went on to Arch, and we started doing David with Arch and elephant trunks and all the whole gamut of valve surgery. So we had presented in Tehran our initial results between 1997 and 2009, and at that time 128 cases were of aortic valve repair in children. These were pediatric repairs. In 62, most of them were VSD ARs or bicuspid aortic valves, and then we were at that time gingerly going into Marfans, and today we are operating a lot of Marfans also, and then we found that we had a very stable result, and we were following them up. The most important thing is that we were having one of the major problems with aortic valve repair which we found was endocarditis in the repaired valve, especially in the early period. And one of the major causes we found was the typical thing is the child gets diarrhea, gets IV fluids, probably junk IV fluids, and we've had coming with fungal endocarditis and all those things. So we were very careful to tell them to be very about endocarditis prophylaxis, and the results have been very good for these sort of patients. So, and incidentally, the first case which was done in 1997 in Jayadeva still continues to follow us up. He would have required a root widening. He didn't require anything, and he got a bicuspid aortic valve repair. He's doing well. And as I iterate, endocarditis is something we have to work on. But then there was a huge number of patients whom we could not repair. And what to do? At that time, Ozaki had showed his method, and we were thinking how to do it. Now, the sizes were not there. And as usual, I went around walking around trying, what can I get? I went around the OT, and I found something looking like a aortic valve. And what I saw was the cardiplegia box. And you can see the corner of the cardiplegia box, and if you look at the corner, it looks like a leaflet, isn't it? So I started cutting it with that, and I started making my own sizes, which you could see there. That was version 1. And we started doing Ozaki. And we got good results at it, and then we started progressively doing it. Initially, we compared it with mechanical valve replacement, and we found excellent results with it. We found excellent regression, and we progressively started doing more and more of these. And as we did, we had an issue with that plastic thing which was there, and it was a compromise. Then I'm lucky that my son decided not to become a cardiac surgeon. He thought that rocket science is easier than cardiac surgery, and so he went to become an aerospace engineer in ISRO. And then by that time, 3D printing, we could get 3D printers, and at home, so I bought a 3D printer, and he helped me design, and we made these sizes. These are this thing for doing it. And we did the first 150 cases, and we followed up the first inning. And it's a new procedure, we did not know. When Ozaki did it, he did it in more elderly people, and we were doing it in younger people. And this is the data which we saw, the first 150 cases which we followed up. We've got the 5-year data now, and 89.6 survival. Now you can see a sharp dip in the initial period, and I'd like to talk about that because we burnt our fingers initially. And the freedom for intervention was there, and actually we did 2 redo Ozaki, and we actually had 1 catheter-based intervention. Now, why did we have that big dip in the initial period? This was not just because of that. So we went back and analyzed. Then we didn't just analyze only the thing, but we analyzed also those homographs which we were putting in the aortic position for kids. We realized that when we have an adult cardiologist seeing the patient, he sees it visually. We also see the size of the thing. They decrease the size up and down the depth. So we don't really pay attention. When we started taking the LVID, D and S and normalizing them using Z values, we found that all our patients who died were having a Z value of +7 and above, +7 and above. So we realized, oh God, we are actually operating footballs and dying. And what happened is our pediatric cardiologists were sending lots of cases for ORATION because we were doing well. So they said, then we realized they either died in the hospital or they died within the next year. So we stopped offering ORATION for patients who have had a LVI or D or S of more than +7. We had a dramatic decrease in mortality. We burnt our fingers in that way, and that's a lesson which I want to share with you people. And we saw even if the mitral valve had a Z value of more than +7, they would get home. But in the next 1 year, they would be all dead. Now at present, another thing that we have seen is that if in the MRI, if we find any lateral scarring in non-ischemic scar present in the lateral wall was the index for mortality. And now we have started doing another thing is we are putting some of these patients on sacubitril valsartan and seeing whether they come down, and if it comes below +7, we have been able to go and operate them. That's something which, but it's still work in evolution. We've got to see what happens to them in further, but so far it looks something good. Now, as far as how was it, we got excellent valve areas, excellent gradients, and we had LV mass regression, volumes came down, and NYHA class improved. And then we started extending it to various other things. So we start with kids. You have a 6-year-old kid with the bicuspid aortic valve, dilated ascending aorta. What are you going to do with it? So then we started tailoring aortoplasty, hoping there were some literature saying that tricuspidization of the bicuspid aortic valve may prevent post-stenotic dilatation and all that. So we initially started doing tailoring aortoplasty. By this time, peers and all started coming up. So then now we have started using proline meshing of the aorta preemptively in kids. For those who have a dilated aorta, and we are doing bicuspid aortic valve. We have done bicuspid valves, we have done unicuspid valves, we have done, and you have to be careful in the bicuspid valve with where the 180 dissing, because when you place the ORATION leaflet, you should see that that the flap which comes should not abut on a coronary, but it can be consistently done with a little bit of this thing. Then we learned one thing. When we started doing, and then suddenly these children started growing. My first ORATION looked like a small kiddo. He became a 6-foot fellow, bulky fellow, and he outgrew his valve. And we had to, and then COVID struck at that time, and we couldn't do the we couldn't time his surgery. Then we replaced his valve. That made, then some of the cases which have outgrown, we have now started doing redo ORATIONs in them. But the thing that we learned is that because it doesn't grow, widen the root, don't try to keep it so that you can delay this. See, because essentially the valve will be okay, but he outgrows that valve. Literally they doubled their size with the pediatric growth spurt. So we started doing that. Then for patients with dilated roots, the dilated ascending aorta, we've done ORATION with the wheat procedure. We have even taken cases with porcelain aorta, decalcified them, and and we have done the ORATION in these sort of patients. We've had interesting cases like a child who had his ORATION done, autopericardial reconstruction, because ORATION doesn't like us using that word. And he came back, he had gone to his hometown and he was playing with the cow, and then the cow had given birth to the calf, and he developed fever. And then when he came back sick looking, we were wondering why the hell this guy is having endocarditis. And in my back of I had my aortic valve repairs who were getting this thing. So we said fungus, gingus, all that, search, what is this, what is that? He came positive for brucella. And the story got confirmed that cow. So we had to treat the child and the cow and the calf. And we did the redo Azaki. Then at that time, and we saw in 2 more cases which had endocarditis, we found that the felt pledget was the one where it was eroding. The only blessed thing that we don't use with foreign material which we use is the felt pledget on the 3 sides. That was eroding. In fact, you could form 3 aneurysmal sinuses. We were wondering why the hell is aneurysm sinuses forming? I mean, aneurysms of the sinuses are occurring. What we realized that they were all pseudoaneurysms because of the burrowing this thing. And unfortunately, we had one child where by the time we could take him in for surgery, that burrowing sinus had probably ruptured and he died. So we stopped using felt pledgets and we started using glutaraldehyde treated pericardium only for the pledgets, after which we stopped getting this problem. And that's something which I would like to share with you people. Then we have even then we started becoming a little greedy or bold or whatever, and we started extending it to pulmonary valve, and we've been doing it. We were originally using monocuspid, bicuspid, and when we started having a homograph bank, and we started putting homografts in that position. But now we are electively, but then the demand for using kids for RVOT reconstruction is so high, so we should keep it for that. So we started using it for pulmonary valve endocarditis, and we have had excellent results. And we have even done, and we are planning to report this, where we did a double autopericardial reconstruction of a patient who had VSD AR and endocarditis, VSD and then pulmonary endocarditis. So we did a double Osaki in that patient, and you can see the excised valve, perforated valve and everything. So we learned that it's a very versatile technique. Well, it becomes a little boring putting 6 leaflets in, to be honest, but it was done. So learning points is don't operate on patients with Z value of more than +7. I think they should go to the transplant pathway. Don't try to do that. Or you should be having, I don't know whether Julius and others can probably tell me whether we should put them on mechanical assist for, let's say, 6 months or 8 months, and then I know that if you put them on temporary mechanical assist for 3 days or 1 week, they're going to die. They can't be weaned. So it need probably, I don't know. And we did another thing. These are long procedures, so we started doing myocardial protection. We were initially using Delnida, and I think I got burnt with that. We are using, we now use conventional St. Thomas regular, and we cool and we do that. And as I said, pericardial roll pledgets. So we are seeing it seems to be a good operation so far, at least out to 5 years. We are having excellent, we are reporting our data, durability. So we did a lot of things, and we continue to want to keep running, and cardiologists are coming up with new things, so we need to be able to offer better and better solutions. So let's keep all running twice as fast, and we have to continue to do so. Thank you. And I thank the association and the members for giving me this privilege to give this association thing, and I have to thank all my junior staff and students who made my life worth living as a teacher. Thank you.
The Indian Association of Cardiothoracic and Vascular Surgeons, by virtue of authority in it, recognizes and felicitates Dr.Prassana Simha Mohan Rao with the C.S. Sadasivan Memorial Oration for his innumerable and noteworthy contributions to the subspecialties of cardiothoracic and vascular surgery. His commendable services to the nation, society, and progress of cardiovascular and thoracic surgery have been recognized in the manner befitting the virtuous memory of Dr. C.S. Sadasivan. In testimony whereof, we have subscribed our signatures and caused the seal of the association to be affixed hereunto on this 17th day of February 2023, duly signed by President Dr. Zile Singh Merwal, Secretary Dr. C.S. Hiremat.
Please stay with us for a moment. We are about to begin the presidential oration session. I request Secretary Dr. C.S. Hiramat to invite our President, Dr. Zile Singh Meherwal, to deliver the presidential oration.
I request members to be seated, please. Close the doors. Dear members, much of the credit for the smooth functioning of Indian Association of Cardiothoracic and Vascular Surgeons in the last 1 year goes to this great gentleman who has a lot of patience. It is my privilege today to introduce Dr. Zile Singh Meherwal. Born in Sharanapur, Uttar Pradesh, Dr. Meherwal also went to school in the same town. He was the class topper all through his schooling years and came 5th in his grade 12th board exams. He went on to King George Medical College, Lucknow, to earn his MBBS, MS and MCH degrees. He continued his excellent academic performance, going on to win 5 gold medals in 5 subjects. Currently, Dr. Meherwal is the Executive Director and Head of Adult Cardiac Surgery, Heart Transplant and VAD Program. He is also the Program Director of DNB CTVS at the Fortis Escort Heart Institute, New Delhi. He has been married to his wife Alka for the last 34 years. We welcome you, Madam, today to this August gathering. She is here amongst us. They are the proud parents to daughter Mohini, who is a master's degree holder from London School of Economics. She lives in UK and unfortunately, as she was not able to make her here today to share this special moment with her father. Dr. Meherwal has been working in Fortis Heart Institute, formerly the Fortis Escort Heart Institute, for more than 30 years. He is part of the founding team of cardiac surgeons at the Escort Heart Institute. Prior to Fortis, he worked as a consultant cardiac surgeon in King's College Hospital, London. His areas of interest include off-pump coronary artery bypass surgery, CABG in patients with poor ventricular functions, multi-arterial CABG with bilateral mammaries, radial artery, combined CABG and carotid endarterectomies, aortic surgeries, heart transplants, and LVAD device implantations. A well-respected senior surgeon, Dr. Meherwal has performed more than 30,000 open heart operations with excellent results. He is one of the pioneers in half-pump beating heart surgery in India, as well as using the radial artery in coronary artery bypass surgery. Dr. Meherwal has perhaps the largest experience of radial artery usage in CABG and one-stage CABG and carotid endarterectomies. He is passionate about organ donation and has been successfully running transplant and LVAD programs. One of his early patients of LVAD is living a normal life even at the age of 81 today. He has been running the DNB CTVS program at Fortis Heart Institute, New Delhi for the last 23 years. A senior and a dynamic surgeon, enjoys engaging with students and conducts multiple wet labs and teaching sessions for them. He keeps himself abreast of all the latest happenings in CTVS and has articles published extensively in peer-reviewed journals. He himself is a reviewer of many journals. Despite the demands of surgery, Dr. Merwal maintains a healthy work-life balance. He keeps fit through the regular practice of yoga. He is a student of Swami Bharat Bhushan, one of the first yoga gurus of India. Dr. Merwal is actively involved in community outreach programs such as through the More to Give program. He has conducted several free cardiac checkup camps, including in rural areas. He is also involved in creating awareness about heart diseases among general public and physicians. As a part of the ISCT's outreach program, Dr. Merwal led an organ donation awareness program on World Heart Day, that is on September 29, 2022. Dr. Merwal is the recipient of several awards and recognitions. Awarded by the President of India, Sri APJ Abdul Kalam, for his contribution in cardiac surgery in the year 2002. Listed in the Marquis Who is Who in the World 2005. Aditya Samman by Government of Uttar Pradesh for contribution to medical field in the year 2005. Entered into Limca Book of Records for performing coronary artery bypass surgeries. Surgery on a 94-year-old man who is the oldest patient to undergo CABG in 2008. Recognition Award by the IMA NatCon 2015. Recognition Award during ATCSA Bangladesh 2016. Lifetime Achievement Award by Shakuntala Singh Memorial Rita Kumar Foundation 2016. Recognition Award by Heart Failure Association of India 2017. Healthcare Excellence Award for Outstanding Achievement in Healthcare by Government of Uttarakhand in 2018. Gem of Healthcare Award by Sri J.P. Nadda, Union Minister of Health and Family Welfare 2018. Best Heart Transplant Surgeon Award during Indian Healthcare Excellence Award ceremony in the year 2020, my apologies. I am grateful for this trust and support that Dr. Merwal has extended to me during his presidential term. He has been instrumental in pushing for upgrading the DNB CTVS curriculum to make the training in India more valid on par with international standards. His patience and analytical thinking have enabled us to take the right decisions at the right time. He has ensured the association moves forward seamlessly in the right direction. He has stood beside me like a rock in continuing the Center of Excellence program, which is an upcoming project, a huge project coming up by itself for the association. I welcome the 53rd President of the Indian Association of Cardiothoracic Vascular Surgeons, Dr. Zile Singh Merwal. Let the video be put on, please. Dear friends, with a round of applause, I request the 53rd President of Indian Association of Cardiothoracic and Vascular Surgeons, Dr. Zile Singh Merwal, to deliver his presidential oration. I request Dr. Lokesh Sajja to join with me on the dais. Thank you, sir.
Respected seniors, colleagues, invited guests from overseas, my dear students, a very good afternoon to you all. It's an honor and privilege for me to stand here and address you as the president of our prestigious Indian Association of Cardiovascular Thoracic Surgery, and I thank you all for this honor. Before I start, I want to thank God for blessing me with more than what I deserve and giving me the strength to accomplish my goals and overcome all the challenges of life. I'm proud and privileged to be associated with the association for the last 4 decades. I attended the first meeting of our association in Srinagar in 1986, when it was held with the Cardiological Society of India. Over the years, our association has progressed from a very small group to a very large association today with more than 1,800 members. And it's a well recognized and respected association in cardiovascular surgery in the globe. Over the last 3 years as executive member in different capacities, and over the last 1 year as president, I had the privilege of working with a very dedicated team of executive members, and I want to thank them all. I want to thank Dr. Bashi, who steered the association during the challenging times of COVID pandemic. Unfortunately, he couldn't make it today, and we are missing him. He kept the morale of the members high and ensured that our academic activities continue for the benefit of our members and students. My special thanks to Dr. Iyer, who has not only contributed immensely to take the association forward, but also he has been a great colleague and a friend for almost 3 decades. I want to take this opportunity to welcome the incoming president, Dr. Lokesh Sajja, who is not only a great clinician, but also a great researcher. I'm confident that he will take the association to further heights. Dr. Hiremath, our young dynamic secretary, is very energetic, proactive, and dedicated member of the association. I want to thank him for his commitment and dedication. Dr. O.P. Yadav, editor-in-chief of Indian Journal of Thoracic and Cardiovascular Surgery, has taken the journal to great heights. He has been immensely contributing during the executive committee meetings with his very valuable comments and advice. I want to express my sincere thanks to him. I want to thank Dr. Rashmi, who took over as Joint Secretary and Treasurer last year. She is working hard to streamline the accounts and auditing processes of the association. I also want to thank all the other executive committee members, Dr. Jagannath, Dr. Samsir Lochab, Dr. Manoj Durairaj, Dr. Alok Mathur, Dr. Bhupesh Shah, Dr. Gaurav Goyal, and Dr. Shiva Muthukumar for their support and contribution. Friends, all of us have been nurtured and supported by individuals who have truly made a difference in our lives. I want to thank my parents, who in addition to providing love and emotional support...
Sir, my apologies. Can the slides be shown, please? They are not been displayed on the screen.
I think we will start them after a little while, I think. Or we can start from here. Yeah, we can display the slides now also.
No, the slides have been planned. They'll come up when required, sir.
Yeah. I want to thank my parents, who in addition to providing love and emotional support, made it possible for me to complete my medical education in spite of all the odds and financial challenges. Most importantly, I want to thank my wife Alka and my daughter Mohini, who have been great source of inspiration for me. My wife has been an enabler in the finest sense of the word. Her support, her sacrifices, her eternal optimism, and her cheerful assumption of family responsibilities has made it possible for me to accomplish my responsibilities in my career. I'm proud of my daughter Mohini. She has inspired me every day to grow and be better. She loves interacting and collaborating with people, and so she decided to be an HR professional. She did her master's from her dream university, London School of Economics, and decided to continue in UK. Friends, for us as doctors, teachers are the most important persons to play a pivotal role in molding us. I sincerely want to thank all my teachers during my graduate and postgraduate education and training for shaping me not only as a good doctor, but also as a good human being. I also want to thank my mentors for their advice, guidance, assistance, and handholding during my cardiothoracic surgical training. I have been associated with several outstanding colleagues over the last 4 decades of my career in cardiovascular surgery, and they are too numerous to mention individually. I want to thank all of them for their support. I thank all my colleagues who have been part of my journey in cardiac surgery at Fortis Escorts Heart Institute, where I have been practicing for more than 3 decades and still continue to practice there. My special thanks to Dr. Naresh Trehan, who nurtured the team at Fortis Escorts Heart Institute, and it became one of the premier and the most respected institute in cardiac sciences in the country. I thank my present team. Many of them are working with me for more than 10 years, and in fact, some of them are actually working for more than 20 years. Friends, without speaking much about myself and my journey, I like to go directly to my topic today, except saying that, like most of you, I joined cardiothoracic surgery out of my passion. These kind of articles, both in the medical journal and in the lay press, are not uncommon. The top one is from the Portuguese Journal of Cardiothoracic and Vascular Surgery. The middle one is from a lay press, and the bottom one is from Medical Student Journal. In fact, very recently, only a couple of weeks back, The Economist published this article entitled "Bypassed Are Heart Surgeons Dying Out?" In this article, the author has expressed his views after her interaction with the cardiologist and the cardiac surgeon at St. Barth Hospital, London. We had to accept the fact that DRNB and MCH seats are going vacant. It's a reality, and we are not able to attract the best talent. So these are realities of our specialty. And of course, we do have challenges in our specialty. It's a demanding specialty. There is too much hard work. The training period is too long. There's late settlement in life. There's difficulties in finding suitable job placement, challenges with work-life balance, and finally, poor reimbursements. But do you say that we are facing the dusk of the field, or are there still many opportunities in cardiac surgery? Friends, I'm not convinced that our specialty is dying. We don't have a future. So I thought today, when I was thinking some time back as to what I should speak on, what should be the theme of my discussion with you, I thought the most vital issue today is talking about the future of cardiac surgery in our country and for our next generation. So I decided to speak on this topic, and this is equal to the challenge cardiac surgery in India as many opportunities as there are challenges. Because I personally feel that we have challenges, but we need to find the opportunities in those challenges to ensure that we go back to the same, we bring back the same glory in our specialty. We encourage our students, our young generation, to the same level where it was a few decades back. We had good time, and we have seen good golden era of cardiac surgery. There was a time when being a cardiac surgeon had a very special allure. Everyone wanted to be around us, everything was glamorous, and the grass was always greener on our side. Operating on the heart, exposing and touching it was only reserved for some special ones. And this was true even when I joined cardiothoracic surgery. We felt unbeatable at that time and highly respected. But in 1977, Andreas Grundig, a German cardiologist practicing in Zurich, changed the cardiovascular world forever. None could foresee his impact, and none thought back then that more than 40 years later, we would be fighting to survive in a catheter-based panorama. And we've all seen the impact of this increasing PCIs in the world. Volume of coronary surgery has significantly dropped, not only in the US, but across the globe. And as if that was not enough, it happened again in 2002, when Ellen Crebier implanted a completely percutaneously deployed valve in the aortic position, was another wake-up call for us as cardiac surgeons. And the impact again we have seen. The number of transcatheter aortic valve procedures exceeded all forms of surgical AVR for the first time in 2019. And this is the trend world over. So do we say that we don't have a future? Do we say R is a dying specialty? I would again reiterate the same. I strongly feel that we do have a good future. I'm not ready to accept that we can't go back to the same level where we were before. There are a lot of opportunities. We need to explore those opportunities. Let me start by this research report by Morgan Stanley on India's impending economic boom. According to this report, India is on track to become the world's third largest economy by 2027, surpassing Japan and Germany, and have the third largest stroke market by 2030. So can healthcare in general, and cardiac surgery in particular, use this momentum in our favor? In fact, the healthcare market is already growing very fast in our country. India's healthcare system has been majorly concentrated in the larger cities, and that's one of the challenges we have to accept. So currently, most of the cardiac centers, they are in the tier 1 cities. Some of them are now going to tier 2 cities. But that scene is changing now, and tier 2 and tier 3 cities are experiencing the healthcare revolution. In fact, in this report, they have talked about the return on investment, which the corporates and the investor look at, that the ROI, or the returns on investment, actually is now better in tier 2 and tier 3 cities. And I won't be surprised if in the next 10 years, we see large number of cardiac centers coming up in tier 2 and tier 3 cities. So there is a changing scenario of healthcare in tier 2 and tier 3 cities. There has been an increased investment diversification for the overall development of healthcare infrastructure in tier 2 and tier 3 cities. And this is exemplified by the fact there are 19 AIIMS in India. Some of them are in relatively smaller cities that are operational as of January 2022. And by the end of 2025, 5 additional AIIMS are anticipated to open in India. Also, the government initiatives like Ayushman Bharat, Ayush Mission, and Pradhan Mantri Yojana are proving to be the game changer for smaller towns. These government schemes certainly, as of today, are not very lucrative and very viable for our specialty, but I'm sure that things are going to change, and this certainly will help us to find many more opportunities in future. If you look at briefly the current scenario of cardiovascular surgery in our country, a rough estimate of more than 400, around 420 cardiac centers in the country, with around 1,200 to 1,300 practicing cardiac surgeons. We perform about 300 cardiac procedures, about 60% being the coronaries. But I'm quite sure that in coming years, the number is going to go quite high, and it actually will increase with a lot of investment in the healthcare in our country. On the other hand, if you look at the number of cath labs, we have more than 2,000 cath labs as of today in India, and many more cath labs are added every year. So do we have an opportunity in this? Of course we do have, because we can affiliate to these peripheral cath labs, and they can be the feeding centers to us for cardiac surgery. We had to collaborate with these cath labs. Friends, we need to do what is known as the SWOT analysis. I'm sure a lot of you know this. Almost all the industries, they do this SWOT analysis, which basically is analysis of our strength, our weaknesses, our opportunities, and threats. We already are doing very well in many areas. We are already strong in many areas. We need to explore further opportunities and more opportunities. Off-pump coronary artery bypass grafting is one of the areas where we are already the leaders. So let me briefly talk about the off-pump coronary artery bypass in our country. The off-pump CABG started in the world in mid-90s. We picked up this technique very fast, faster than other parts of the world. And while in North America it peaked to 25%, and there has been a steady decline after that, it's increasing in India. Currently, about 60% of patients undergoing isolated CABG are operated off-pump, and our young generation, in fact, a lot of them have been trained in off-pump CABG to the level that they can do it very comfortably. The benefits and risk of off-cap have been subject of several large randomized controlled trials, hundreds of observational studies, many registries, and more than 60 meta-analyses. I certainly can't discuss all of those, though there have been concerns in OPCAP, specifically related to technical complexity, completeness of revascularization, and graft patency in the long term. It's not possible to discuss those studies, but there is a lot of publications in the world comparing the OPCAP with the on-pump technique, looking at the midterm and the long-term results, including studies from India. But I'd like to mention two studies specifically. The first is the coronary trial. This was probably one of the largest trials comparing the results of off-pump versus on-pump. It was a multinational trial, and many centers in our country, including our center, was part of this study. The 5-year data shows that there was no difference in the composite of death, known fatal stroke, known fatal MI, known fatal new renal failure, and repeat revascularization at 5 years. An important thing I'd like to mention here, that one of the important inclusion criteria in this study was the surgeon experience. And only the experienced surgeons were allowed to participate in the study. And the expertise was defined as more than 2 years of experience after residency program and completion of more than 100 cases of a specific technique, either on-pump or off-pump. And importantly, the trainees were not allowed to be the primary surgeon, which has been the case in many studies where the results of off-pump have been shown to be inferior. The second study which I'd like to mention is the ad hoc analysis of the ARTS trial. I'm sure all of you are aware of the ARTS trial, which is one of the largest randomized trials. It was not designed to compare the off-pump versus on-pump. It was designed to compare the results of single internal memory artery versus 2 internal memory arteries. But they did the post-hoc analysis of this trial, comparing the off-pump and the on-pump results, and published these 10-year outcomes. And at 10 years, there was no difference in all-cause mortality and death, myocardial infarction, stroke, and revascularization. An important analysis from this trial was that off-pump surgery performed by low-volume off-pump surgeons was associated with a significantly lower number of grafts, increased conversion rates, and increased cardiovascular death with a hazard ratio of 2.39 when compared to on-pump surgery performed by on-pump surgeons only. Let me briefly show you our experience and our growth and our journey of using the off-pump technique at our institute. We started doing off-pump surgery in mid-90s, and we presented our first experience of off-pump CABG in 5th annual meeting of the International Society of Minimally Invasive Cardiac Surgery in 2002 in New York. And in fact, at that time, this was the largest experience from one institute of off-pump CABG. We analyzed our data of close to 5,000 patients of multivessel coronary artery disease undergoing off-pump CABG and compared it with on-pump surgery. As you can see, between 97 and 2099, about 16 to 18% of patients were operated off-pump in our institute. In 2000, it was about 50%, and after 2001, more than 90% of patients are operated off-pump. Currently, about 98 to 99% of our patients undergoing isolated coronary artery surgery are operated off-pump. We analyzed our results, and 30-day mortality, and the outcome was found to be better in the off-pump technique. A few years later, we analyzed our data of more than 14,000 patients who underwent off-pump CABG and compared them with the on-pump technique. An important metrics in off-pump surgery is your conversion rate, because this has been one of the concerns in many studies, because if the patient needs to be converted from off-pump to on-pump, the outcome, which as has been published, has been quite poor. As you can see, our conversion rate dropped from 5.9% in mid-90s to 1.7% after 2000. We also analyzed our data in a subgroup of patients, including elderly patients, patients with left ventricular dysfunction, high-risk patients, and many other categories. However, I had to acknowledge that all these are observational retrospective studies, and they have their own limitations. And it is not only in us, I think, as I mentioned, in our country, large number of surgeons are using this technique in isolated coronary artery disease. So can we use this as an opportunity in our country? Yes, we can, because with better early outcomes, it leads to shorter ICU stay and shorter hospital stay, which obviously would be more cost-effective, and it can be practiced in small centers with limited resources. Before I move on, I'd like to tell this story of Pandora box. I'm sure a lot of you must have heard about this story of Greek mythology. Zeus made Pandora the first mortal woman because he was mad at Prometheus, who had given the mortals special gifts, so he decided to give one more, and that was Pandora. Each god gave something to Pandora to make her perfect. Venus gave her beauty, Mercury gave her persuasion, Apollo gave her music, and so on and so forth. And finally, she was ready for Earth. Zeus gave her to Epimetheus, who was Prometheus' brother, who had said to Epimetheus not to take anything from the Olympians, especially Zeus. And Epimetheus was about to decline Pandora, but as soon as he looked at her and saw her beauty, he accepted Zeus' gift. And Epimetheus gave Pandora a box and advised her not to open it. She was forbidden to open. She was curious always to open this box. Every day she wondered what was in the box. She knew she shouldn't open it, but she was extremely curious and could not bear not to know its contents. And as soon as she pulled the cover off, all the evil and mistrust flew out into the world. And when Pandora looked at the bottom of the box, she saw that the only thing left was hope. So friends, we have to look deep we'll find lots of hopes, lots of opportunities. It's only the question as to how we explore those opportunities and use them in our favor. So let me speak a bit about other areas where we have still a lot of opportunities. The minimally invasive cardiac surgery program in our country is quite sound. A lot of centers are using this program, but we still have a lot of opportunity in this area. Many centers are doing extremely well in aortic surgery, but this is one area where I think there is a lot of opportunity for a lot of centers and a lot of our young surgeons. The heart and lung transplant is certainly growing. I'll speak a little bit about this one. And finally, there's a lot of opportunity in the pediatric and congenital heart surgery with large number of patients who need corrective cardiac surgery. Let me speak a little bit about heart and lung transplant, which is very close to my heart. I think many of you, at least those who are involved in the heart transplant program and those who have worked in the UK, know this hospital, Hayfield Hospital. At one point of time, Hayfield Hospital was doing the largest number of transplants in the world, and even today is one of the leading centers. When I was practicing in King's College Hospital, London, out of my clinical interest, I decided to spend a few weeks in this hospital to look at their cardiac surgical program, but specifically to look at the transplant program. So as I used to go to Hayfield Hospital whenever there was a transplant, which is normally in the middle of the night. But at the back of my mind, I always used to think if it can ever be a reality in our country. But interestingly, the same month, while I was visiting the Hayfield Hospital, this news came from India when India performed the first heart transplant at All India Institute of Medical Sciences on 3rd of August, 1994. So it was obviously a great news for India. It was covered by most media in India, but also outside India. I was so happy and excited to read this news, and I thought it certainly will be a reality in our country too. But for almost 2 decades, there was not much of an activity in this field. But I must say for the last 10 years, there is a significant increase in the activity in the area of heart transplant, and now also for the last few years in lung transplant. In fact, the number of transplants between 2015 and 2018 almost doubled. Now, in terms of the absolute number, as well as the rates per million population, is very low as compared to the global numbers even today. But I am quite sure that with the increasing interest of a lot of surgeons in this field, the numbers are going to increase, and I won't be surprised if after 10 years, we probably would be doing a few thousand of transplant with increasing donation activities and increasing awareness. Of course, there is challenges in heart transplant, and this is related to infrastructure, trained manpower, donor availability, for referral by physicians, and cost. But I must say, a lot of these are changing. We have trained manpower now. The donor awareness is increasing, specifically in the southern part of the country, but also in a lot of other states. The physicians are aware now, the cardiologists are aware that this is probably the best therapy for end-stage heart failure. And even the cost not only is expected, I will believe to come down, but more importantly, I would expect that the government would support this program, which is already being supported in southern states, including Tamil Nadu. So friends, this is one area where I feel there is a lot of opportunity for our young surgeons to take up as a super subspecialty and excel. One important thing I'd like to mention, that though we are one of the world's leading nations in the volume and quality of many cardiac procedures, but we need to analyze, present, and publish our data. We still lack good articles from our country, even though we have good volumes and even large centers. The good articles are not published very often, so I think this is one thing which we need to do, not only to present ourselves at the international forum, but also to communicate with the government organizations as to what we are doing. And with the same aim, we need an Indian cardiac surgery database. It's a requirement today. I think we all need to work on this. The attempts have been made in the past. I'm happy to say that IACTS is working very hard over the last 2 years under the chairmanship of Dr. K.S. Iyer on making this Indian database a reality. I want to thank and congratulate the IACTS Database Committee for their efforts. I also want to thank Venkat, who is helping us in this mission from Australia, and also Raghuram, who is our database manager. We currently have 12 institutions entering data in the database, with more than 14,000 patients already entered till last month. Dr. Iyer will be presenting the first national database in this meeting. I appeal to all the surgeons to register their institutes in the database and be part of this database so that at the end of a few years, we can have a truly national database. Let me just speak a little bit about medical tourism because this is another area of opportunity and another opportunity for us, not only in healthcare in general, but also in cardiac surgery. And it will give us a lot of opportunity to increase our practice in cardiovascular surgery. India today is the preferred destination for medical tourism. In fact, India's medical tourism is amongst the fastest growing subsectors in the industry. There are many research reports, including KPMG, according to which, with its key differentiating factors of extremely competitive pricing, highly trained doctors, high quality care, and availability of a range of treatments, India has realized the potential of medical tourism and has positioned itself as one of the largest service providers in this region. This is a very recently published research article in Dublin, in Ireland, looking at the Indian medical tourism market between 22 and 27. According to this report, India medical tourism market is expected to generate $35 billion in 2027 from $5.63 in 2021. And it says it is because of the world-class doctors and hospitals, where the cost of treatment is a fraction of price in the source markets, with no waiting period for medical processes. Also, increasing popularity of India as a medical tourist destination in African, Middle East, and Asian countries. And it says that India has the Eastern healthcare wisdom along with expertise of Western medicine. This research report has analyzed the cost of CABG in selected countries in 2019. And as you can see, the United States is at the top with $120,000 as the cost of CABG, as compared to India, which is at the lowest with less than $8,000 US. And in fact, we are cheaper in comparison to our many competitors, including Singapore, Thailand, Turkey, and Malaysia. But an important thing which we also have to remember, that now is the time when we have to change our mindset. We have to change the way we have been practicing for many years. I think all of us know that so far we have been relying on our cardiologists and physicians to refer the patients to us. And with increasing number of interventions, this becomes a conflict of interest. So we'll have to provide the leadership and be the watchdogs as the cardiovascular therapeutic space moves forward. And I think with the same aim, the IACTS launched this IACTS outreach program. This was launched on 29th of September last year on World Heart Day. The reason why it was launched and the vision of this program is to reach out to the public through social media and outreach events. So we need to reach out to the public directly so that they are aware of not only what we are doing, but also to engage with the public to foster cardiac health, disseminate knowledge regarding heart disease, and also to make them aware of the best treatment available, which is based on the scientific evidence. So basically what it means that if a patient has a coronary artery disease, gets an angio, and needs treatment, at least we should be able to guide them and at least make them aware about the best treatment available based on the scientific evidence. And we also want to ensure the best standard of care to our patients. And the social media, as all of us know, is a very strong platform anywhere in the world, and India certainly is using the social media very strongly. So it's a powerful mode which we can use in our favor. And finally, I think to reach where we want to reach, to explore more opportunities, ensure that we go back to the same where we were before, we seriously need to look at our cardiovascular thoracic training. The cardiothoracic curriculum, which was probably designed many decades back, certainly needs to change. The contemporary cardiac surgeon today needs a triad of required expertise to master the full spectrum of therapeutic options in cardiovascular surgery. And this includes not only the surgical expertise, which was enough few decades back, but this also needs the imaging expertise and catheter expertise. And this is very clear from this slide, which I had shown in the past, how the number of transcatheter aortic valve procedures are taking over the surgical aortic valve procedures. So do we take it as a threat? No, we should not take it as a threat. We should enter into this area, we should train our young surgeons in catheter-based skills and take this as an opportunity to expand our practice. There are many programs in the world who started TAVR program, and they were led not by the cardiologist, but by cardiac surgeons, even many programs in US. You would be interested to know that the proctor who came to us to help in our first patient when we started the transcatheter program at our institute was Dr. Thomas Modine. Thomas Modine is a practicing cardiac surgeon in France, and a large area of his practice is structural heart disease. And he very clearly said that we as cardiac surgeons should enter into this area of structural heart disease and should lead this program. So we need to certainly have a relook at curriculum of DRNB as well as MCH program. The catheter-based skills need to be included, and it is not only these skills, a lot of other areas needs to be changed so that we can prepare our next generation to widen their field of practice and not only being totally dependent on the number of patients, whatever is referred from the cardiologist. With the same aim, the IACTS has a vision of creating a center of excellence, and basically the idea behind center of excellence is that we should have our own facility, which we can use not only for academic activities, but also to conduct wet labs, the hands-on experience, the catheter-based skills, simulation, training programs, and many more. Dr. Hiremat would be presenting this in the general body meeting. Friends, whenever there is a challenge, there is always an opportunity to face it and to demonstrate and develop our will and determination. I'm sure some of you might be knowing that every president of the United States, when he leaves office, leaves on his desk a confidential letter to his successor of unfinished tasks and outlining the important issues facing the nation. Today, if I have to outline most important issue facing our specialty and our association to my successor, Dr. Lokeshwar Sajja, and to all of you, I would say, let's work together to create positivity in our next generation. Let's focus on teaching and training and mentorship. Let's work towards attracting talent to our specialty. And let's convert our challenges into opportunities to continue to serve the society. We are cardiovascular surgeons. The confidence flows in our blood. And I strongly believe we are all born with the ability to change. So let's change our challenges into opportunities. And with that, I once again thank you for the honor of serving as your 53rd president. Thank you very much.
The Indian Association of Cardiothoracic and Vascular Surgeons is honored to recognize and felicitate Dr. Zile Singh Merwal for his service to the association as its honorable president between 2022 and 23. His innumerable and noteworthy services remain in the indebted and grateful recognition by the association, its fellows and members. Awarded this on the 17th day of February 2023 at Coimbatore.
Thank you, sir. We will now take a break for lunch. We will resume all the lectures at 2 p.m. sharp.
what,